Welcome to Future Horizons in Fibrosing Interstitial Lung Diseases, a focus on idiopathic pulmonary fibrosis and progressive pulmonary fibrosis. I'm Lake Morrison. I'm a director of the ILD clinic at Duke University and associate professor of medicine here. I'm joined by my counterpart at Yale, Dr. Danielle Antonozurkis. Our objectives today are to describe the pathophysiology, prevalence, and burden of disease in fibrosing interstitial lung diseases such as IPF and PPF. We want to identify practices for early diagnosis and routine assessment of patients with these conditions according to current guidelines. We're going to summarize the latest developments in clinical research and emerging therapies for the treatment of these entities. To start, let's briefly revisit the pathophysiology, prevalence, and disease burden of these conditions. Okay, let's start off with a case. We have a 65-year-old man with a history of rheumatoid arthritis. He was diagnosed 4 years prior with a positive rheumatoid factor and CCP. He used to smoke, but no longer does. His joint disease is well controlled. He has been complaining of dyspnea on exertion over the last 6 months. It seems to be worse on hills during his routine walk. He's not wheezing and he doesn't have any edema. He had a cardiac workup which was completely unremarkable. He had stress testing and an echocardiogram. There's no evidence of pulmonary hypertension or ischemia. In retrospect, he did have a chest x-ray for another reason 4 years earlier, which was completely clear. On pulmonary function testing, he has an FVC of 109%, but a DLCO was reduced at 66%. When we look at his CT scan, we see some peripheral interstitial markings. We see some ground glass and reticulation. I think there may be some traction, but I don't see any honeycombing. So let's talk about interstitial lung disease in general. This is a broad term covering over 200 disorders depending on how you parse it out. All of these conditions can affect the pulmonary interstitium, the structural network supporting the alveoli and capillaries. If you think about a microscopic level, the alveolar epithelial cells and the capillary endothelial cells share a common basement membrane. This leads to a potential space between the alveolus and the capillary, but usually one that is not occupied by much. You can see that in the picture here with the nice lacy structure of a normal lung. Unfortunately, on the right-hand side, you see what happens when there's an interstitial lung disease, and that potential space gets filled with collagen or inflammation. When that happens, we see reduced lung volumes, impaired DLCO, hypoxemia, progressive dyspnea, respiratory failure, and death in many cases. I want to introduce you to the diagram shown here, capturing inflammatory diseases, fibrotic diseases, and those with features of both. For pure inflammation, like the organizing pneumonia we see on the left here, complete resolution with therapy and/or exposure removal is common. For fibrotic diseases with prominent honeycombing, like we see on the right here, we typically see relentless progression of disease, ultimately leading to respiratory failure. Not surprisingly, we get a mixed bag of responses for those processes that fall in the middle, with both inflammation and fibrosis. Now, don't panic. I'm not going to go through this physiology diagram in detail. I do want to point out a few things. First of all, it starts at 11 o'clock and goes around this alveolus depiction to 1 o'clock in a counterclockwise fashion. We believe that fibrosis starts with injury to the type 2 alveolar cell, like we see at 11 o'clock here. This sets up an injury response that ultimately recruits fibroblasts. This is how normal wound healing proceeds. In pulmonary fibrosis, something occurs that makes the wound healing abnormal, in that the fibroblasts not only invade this space, but they also proliferate and stay, which we see at 5:30 or so in this diagram. Some of the fibroblasts differentiate into myofibroblasts, which have contractile properties that lead to volume loss. A vicious cycle of ongoing extracellular matrix deposition then ensues. In the end, that thin potential space we saw between the alveolar epithelial cell and the capillary endothelial cell is completely expanded and filled with collagen. This results in gas exchange impairment, stiffness of the lungs, and the honeycombing we see depicted up at 1 o'clock. When we consider why this occurs, it's important to recognize that this does not happen to most people. Pulmonary fibrosis is rare. It seems that at least some, and maybe all folks, have some sort of genetic susceptibility. Environmental exposures seem to be important. These include tobacco, gastric contents, and protein antigens, for example. In autoimmune diseases, we expect that the immune system itself is the culprit, as we clearly see more inflammation on histopathology in these disorders. What throws the switch to turn on an abnormal wound healing response is unclear, but persistence of the trigger and/or another process, possibly in conjunction with aging or infection, likely plays a role. In the end, depending on the process, we can see just inflammation, pure fibrosis, or a combination thereof. And this is really the holy grail. What turns on this pro-fibrotic switch? So let's look at the spectrum of fibrosing interstitial lung diseases. 10 to 15 years ago, this slide would have been presented as IPF in the middle and all the other entities as being separate. There would not be any overlap like we see in the white shaded area here. We now fully recognize that many interstitial lung diseases, which start out less threatening than IPF, can at times progress to relentless fibrosis and can ultimately end up looking like IPF at advanced stages. Let's look at IPF and PPF in a bit more detail. IPF is a chronic fibrosing interstitial pneumonia of unknown cause. It's almost universally progressive. It's the most common form of idiopathic interstitial pneumonias and would account for about a third of the patients seen in a subspecialty clinic. UIP is the hallmark radiologic and histopathological feature. In the imaging we see here, there is lower low peripheral reticulation, shown by the blue arrows, traction bronchiectasis, which we see with the green arrows, and frank honeycombing, which we see with the yellow arrows. Risk factors for developing pulmonary fibrosis include older age, male sex, genetics such as telomere length or MUC5B mutations, a prior history of smoking, other environmental exposures, and possibly gastroesophageal reflux disease. Progressive pulmonary fibrosis, on the other hand, refers to interstitial lung diseases other than IPF. It's not a distinct disease, it's agnostic to the underlying condition, but in many ways it behaves like IPF. We have radiographic features that help define this entity as well as symptom features. If you look at the chart here, if you have 2 of 3 of these changes that indicate progressive fibrosis, then you meet the definition of progressive pulmonary fibrosis. These include symptoms, PFT abnormalities, and disease progression as evidenced by high-resolution CT scan. So how common is PPF? On this typical ILD chart, pay attention to the areas shaded in blue, as these reflect the prevalence of PPF in several conditions, including the idiopathic entities, most autoimmune diseases, hypersensitivity, and other exposure-related diseases like dust, and even tobacco-related diseases, and of course, sarcoidosis. I'm sure this is purely referral bias, but I personally think that PPF is much more common in these entities than we are seeing here on this ATS consensus statement. And just a reminder, IPF is not common, probably about as prevalent as pancreatic cancer. Note here that PPF is more common than IPF, and that's probably reflecting the fact that the underlying conditions are much more common than IPF, such as rheumatoid arthritis, Sjogren's, or lupus. IPF and PPF are expensive in a macro sense. These patients are typically seen 3 to 4 times a year. They benefit from expensive medications and ancillary therapy like supplemental oxygen and pulmonary rehab. Progression of disease might ultimately include consideration of lung transplantation, which is, of course, very expensive. In the figure on the right, you can see that the cost of care for PPF is double that of non progressive interstitial lung diseases. On an individual level, these diseases can be absolutely devastating with severe loss of quality of life. Patients often have to stop working, they lose their independence, their worlds become progressively smaller, often at a time of life when they had hoped for so much more. For follow up on our RA-ILD patient we talked about earlier, we see progressive loss of lung function, worsening images, and worsening symptoms. He now needs oxygen with exertion. He meets all the criteria for progressive pulmonary fibrosis. He is appropriately referred for lung transplantation evaluation. All right, so some key takeaways from this part of the talk. IPF is a progressive disease, but other forms of fibrotic interstitial lung disease may progress as well, require monitoring. Fibrosing interstitial lung diseases are associated with impaired quality of life and higher healthcare resource utilization. To document and determine whether patients have progressive fibrosis, we want to look at their spirometry, their gas exchange, or hypoxia, whether the CT scan is changing, and whether their symptoms are worsening. All right, so let's talk about optimizing the diagnosis and routine assessment of patients with both IPF and PPF. Let's now talk about a case of a 45-year-old woman with scleroderma. She was diagnosed 4 years prior with Raynaud's and noted some puffy hands and skin thickening in the last year. More recently, she's noted mild dyspnea on exertion in her exercise class, but she wondered if it might just be due to gaining weight. Her ANA is positive in a nuclear pattern, as is her SCL70 antibody. I want to briefly mention delays in diagnosis. Given how rare these diseases are, it's not terribly surprising, but early PFTs and chest imaging can lead to at least basic recognition that some sort of ILD is present, prompting early referral. These delays, which can be a couple years in some studies, lead to significant lost therapeutic opportunities. I do want to mention now that we have formal guidelines from the American College of Rheumatology and American College of Chest Physicians regarding screening and treating autoimmune rheumatic lung diseases. We also have new guidelines from the ATS for the evaluation of interstitial lung abnormalities, or ILAs, which is the presence of radiographic changes in the absence of clinical disease. We'll cover the autoimmune statement in this talk, but not ILAs. Focusing on the ACR guidelines for a moment, here's a flow diagram on the left for how one might proceed with evaluating for the potential of interstitial lung disease in these patients. On the right-hand side, we see various conditions, antibodies associated with those conditions, as well as other clinical features which might point to the presence of them having an interstitial lung disease. Going back to the diagram on the left, if we diagnose an interstitial lung disease, we want to follow them with pulmonary function testing and imaging and other ancillary testing in the framework suggested in the box on the bottom on the left. All right, so let's look at another case. Here we have a 78-year-old man with mild dyspnea over the last 6 months. Some medical history notable for hypertension, coronary disease, and diabetes. He did have a recent cardiac workup, which was negative for ischemia. He's on a statin, a beta blocker, and metformin. He used to smoke, but no longer does. He has no worrisome exposures either at home or at the workplace. Review of systems reveals no suggestion of autoimmunity. On exam, at rest, he's 98% in room air. But listening to his lungs, we hear fine Velcro crackles at the bases bilaterally, most prominently heard actually laterally. There's no evidence of an inflammatory arthritis and no mechanics hand. He doesn't have Raynaud's, digital ulcerations, or sclerodactyly. Pulmonary function tests include an FVC of 76%. He is not obstructed. His lung volumes are also impaired at 70%, and his DLCO is as well, also at 70%. When he walks, he desaturates to 96%. He covers a distance of 1,200 feet, which is 88% predicted. Here's his CT scan. We see changes that are peripheral, they're lower lung predominant, there are reticulations, traction bronchiectasis. Importantly, there's no honeycombing. See kind of minimal ground glass just in the periphery. I don't see any evidence of my air trapping or mosaicism. We do see a hiatal hernia. Despite the overlap in IPF and PPF, we still take a pretty simple approach to IPF. We essentially rule out IPF when we establish a relevant autoimmune disease or identify exposures with compatible data. HRCT is critical in this evaluation, with the appropriate protocol including thin 1 millimeter cuts in inspiration and expiration, as well as prone imaging, at least at the outset. Unlike many diseases where pathology trumps all other data, the gold standard for diagnosing IPF is the multidisciplinary discussion, which is a meeting of the minds that includes pulmonologists, radiologists, pathologists, and ideally rheumatologists. This is just a reminder of what we might be looking for when we want to diagnose connective tissue disease. You'll see various symptoms listed on the left, antibodies we would want to send for these various conditions on the right, and some features that you might commonly see, like Raynaud's in the one picture on the left and a mechanic's hand rash in the picture on the right. Exposures can be challenging to identify, but questionnaires given to patients in advance can be helpful. There are several available online, including a couple nice ones from the ACCP. It's important to realize that patients may not know about exposures, and you might want to consider using environmental hygienists for the evaluation of their HVAC systems, for example. And don't forget to ask about birds. For some folks, asking about pets won't cut it. I learned this the hard way my very first month in fellowship. For medications, Pneumotox is a wonderful resource. It's really indispensable in evaluating the possibility that a medication a patient is on might be leading to the lung disease. Some of the more infamous ones are listed here. And back to the CT scan. In terms of what we're looking for in our properly protocoled CT, UIP remains the anchor. We have a nice example here of definite UIP pattern that includes peripheral and basal distribution, articulation, traction, and honeycombing. Don't get overwhelmed by what we see here, but I do want to cover the terminology. UIP is just as we described, the pattern associated with greater than 90% of finding UIP on a surgical lung biopsy. When we get to probable UIP in the next column, we have all the features of UIP that we saw in the definite pattern, but we don't have honeycombing. When we see this, there is a 70 to 89% chance of identifying UIP on surgical pathology. Indeterminate basically has suspicious features, but has not really evolved into a clear-cut pattern. Confidence in the pathology with this entity is obviously lower. And then the final column shows features that point to other processes, which we will see in the next slide. On the left-hand slide here, we see a classic example of NSIP, or nonspecific interstitial pneumonia. In this case, it's in a patient with scleroderma. We see extensive ground glass, traction bronchiectasis. you can get a sense of peripheral sparing. On the right-hand panel of images, we see organizing pneumonia that we'd be seeing dermatomyositis. There's consolidation with frank air bronchograms as well as some areas of ground glass. Here's a flow diagram for how a typical MDD would work. HRCT is critical in the evaluation, as you can see here. Importantly, the MDD must meet before invasive procedures like lung biopsies are considered. We'll go through this in a little more detail when we get back to our case. Bronchoalveolar lavage probably has more of an important role in non-fibrotic interstitial lung diseases than in fibrotic ones. Evaluating for alveolar hemorrhage, eosinophilic lung disease, or even Langerhans cell could be done with a BAL. In fibrotic interstitial lung diseases, the main reason we do BAL would be to rule out infection. There are some conditions like hypersensitivity pneumonitis where a BAL lymphocytosis might help support the diagnosis, and very rare conditions where, like borreliosis, where a BAL lymphocyte proliferation might help. But for the most part, BAL is not an important part of evaluating pulmonary fibrosis. Please consider surgical lung biopsies very thoughtfully. Will it truly change management? In general, fibrotic lungs just don't like to be manipulated. Sicker patients are at an increase for an acute exacerbation. It's never good to suspect an entity, confirm it on biopsy, but then trigger an acute exacerbation that carries a patient out of their transplant window. Cryobiopsies and traditional transbronchial biopsies have roles in some entities and should be considered in certain cases. Gene expression testing of tissue samples can help, and emerging therapies like endobronchial optical coherence tomography might someday have a role in helping diagnose interstitial lung diseases. As mentioned, these are the members of the MDD with descriptions of their roles, and of course it is essential to keep the patient at the forefront of decisions regarding diagnosis and treatment. It's obvious, but the benefit of talking to your colleagues and primarily reviewing data cannot be overestimated. So let's go back to our case. We didn't find any potential cause of his interstitial lung disease. His chest HRCT pattern was in a UIP or a probable UIP pattern. In this case, it was probable. The MDD met and decided that there was no need to pursue surgical lung biopsy, and he was diagnosed with idiopathic pulmonary fibrosis. Communicating with patients about their diagnosis is obviously critical. It informs prognosis and helps with treatment strategies. We may want to start patients on antifibrotics, immune suppression, or some combination of the two. If there's an exposure or drug that might be causing their interstitial lung disease, we obviously need to remove that. And it's also time to talk to patients about enrolling in clinical trials. Ultimately, patients may strongly want a biopsy. Make sure they know the risks. Make sure they know the possibility of non-diagnostic pathology, and make sure they know that it could trigger an acute exacerbation. But keep in mind that a biopsy still can be important in management. I would say I get the most from a biopsy when a patient either does not tolerate therapy or it is ineffective. If I know from pathology, for example, that there are prominent lymphoid follicles in the specimen, I would augment or change agents. If I didn't have any pathology, then I might conclude that they just failed empiric immune suppression. So the radiographic pattern may be very helpful in guiding our approach. Some patterns suggest particular diseases quite strongly. NSIP is common in connective tissue disease or autoimmune rheumatic diseases such as scleroderma. Organizing pneumonia can be seen in conditions like myositis. Lobular air trapping and upper lobe predominance might suggest hypersensitivity pneumonitis. However, the radiographic pattern is not the whole story. For example, UIP with no known cause is IPF. But UIP could be seen in other conditions. So if you have UIP with rheumatoid arthritis, like we saw earlier in this talk, that would be RA-ILD and not IPF. So some key takeaways. There is a role for screening high-risk patient populations. HRCT is the key for the diagnosis of IPF and PPF, but the gold standard remains the multidisciplinary discussion. At a practical level, you need to evaluate for autoimmune diseases carefully. Full environmental and occupational history, as well as a home history, is important. Multidisciplinary evaluation is crucial, and you really need to talk to your colleagues before you consider a biopsy. And now my colleague Danielle Antonozerkis will discuss future horizons in treating fibrosing interstitial lung diseases.
I'll start by talking about future horizons in the fibrotic interstitial lung diseases. So let's return to the case that you just heard about. This is, again, to remind you, a 78-year-old man who had no evidence of connective tissue disease or exposures to explain his lung disease, had probable UIP radiographically, and was diagnosed ultimately after multidisciplinary discussion with IPF. So let's talk a little bit about the kinds of therapies that you might think about with a patient like this. Which are the most appropriate treatment options? A trial of immunosuppression, such as with prednisone and azathioprine. B, pirfenidone. C, nintedanib. D, proton pump inhibitor. E, no therapy, watch and wait. Or F, enrollment in a clinical trial. You can choose all that apply. The ATS-ERS guidelines really offer us a basic approach for how to manage IPF. And really what we're thinking about here is a multi-pronged approach. We want to consider pharmacologic therapy, and that is antifibrotic therapies that we'll talk about in just a moment, and also supportive care with non-pharmacologic options such as oxygen and pulmonary rehab, thinking about comorbidities such as pulmonary hypertension, reflux, etc. And we really want to be thinking about monitoring for progression in this group of patients. These are patients who we know will progress. We want to be considering pulmonary function testing, HRCT, and when they have acute worsening, thinking about such etiologies as pulmonary embolism, heart failure, or an acute exacerbation of disease. And because we know these patients will progress, lung transplantation should be raised in their management, and there should be consideration for evaluation and listing where appropriate, and palliative care should be brought in really as much as possible to help with symptom control. As we're talking about the treatment for IPF, what I do want to mention is what we don't do in this patient population, which is immunosuppression. The Panther study, done more than a decade ago, showed that immunosuppression really is fraught. And so there was increased mortality, more adverse events, and more drug discontinuations, and no benefit to immunosuppression in this patient population. So the drugs that we do consider in IPF are the antifibrotic drugs. So nintedanib and pirfenidone are both approved drugs for IPF in the United States. They both slow the decline in lung function equally. They're both oral medications. When selecting one or the other medication with a patient, often it is the side effect profile or the patient's comorbidities that help us decide between the two drugs. So with nintedanib, this is a BID drug. The major side effect is diarrhea. And this does happen in a significant number of patients, but it actually can be managed in many patients with dietary modifications, with antidiarrheal use, and sometimes with dose reduction. Another issue with nintedanib to consider is the combination with anticoagulation. The initial studies did not allow this because of the mechanism of the drug, and there is the potential risk of bleeding in this patient population, so something to consider in patients on anticoagulation. With pirfenidone, diarrhea is not nearly such a significant issue. There can be some GI side effects, including nausea, occasional diarrhea, or some bloating, but it generally is well tolerated from that standpoint. The major side effect to warn patients about is the risk of photosensitivity. And so really covering up in the sun, using sunscreen is a major issue for this. Both require LFT monitoring, as there can be hepatotoxicity, and this can be modified through dose reduction or stopping the drug. I want to highlight some ongoing trials in IPF. This has been a really exciting time in the world of pulmonary fibrosis with a lot of attention to the various mechanisms involved in the fibrotic pathways. This just gives you a sense of some of the studies that are ongoing now. One that I would like to highlight for you is a recent study that came out looking at nerandomilast. And this is a PDE4 inhibitor that was used at 2 different doses versus placebo, was recently announced, and as showing a reduction in loss of lung function in both doses. And it seemed to have a much better side effect profile than the other drugs currently available. It's currently at the FDA awaiting evaluation. So where this will fit into the treatment of patients in IPF who are already on medications or not yet on medications is still unclear, depending on their assessment of the data and the results of that decision. So let's turn our attention to the treatment of progressive pulmonary fibrosis. So in this situation, there's actually no one standardized approach that can be applied to every patient who has progressive fibrosis. The approach is really focused on the actual primary diagnosis carried by the patients. For some patients, this may include corticosteroids and other immunosuppressive medications. Antifibrotics are a significant option here. But where it's really important to mention why the diagnostic approach that you heard about earlier is so important, if you find something that is potentially removable, that should actually be implemented. So, for example, if there is a bird in the home or if there's a drug that is found to have drug toxicity, removing those exposures is really the most key in treating the patient. No amount of immunosuppression is going to overcome some exposure that is ongoing. In the area of connective tissue disease, this is really a multidisciplinary approach where pulmonologists and rheumatologists really need to agree on treatment strategy, as it may revolve around other manifestations of the connective tissue disease, such as the joint disease in rheumatoid arthritis, the skin and scleroderma, or muscles in the myositis group of patients. Immunosuppression is the only thing that may improve lung function, and so patients do need to be counseled that if the goal is improvement in lung function, that antifibrotics are not going to achieve that, as they only slow future progression. I like this slide in that it really gives us a sense of the differences and similarities in terms of treatment of IPF and non-IPF ILD. So in IPF, we know that these patients will progress, and so the treatment from the time of diagnosis is antifibrotic therapy. It's different in non-IPF interstitial lung disease. There may be patients who have mild and stable disease and are at low risk for progression, and treatment may not be indicated initially. For inflammatory disease, immunomodulatory therapy may be added, and when there's progression despite this, antifibrotic therapy can be combined with immunomodulatory therapy. I think it's helpful to think about some of these patients, especially the ones with connective tissue disease, in trying to decide who you treat and when. There's no absolute disease amount cutoff that will tell you that you must treat a patient. It's really a gradation. So increased extent of CT abnormalities, PFT abnormalities, and symptoms might lean you more towards treatment. Certainly acuity of onset makes treatments much more important, but there's no one thing that makes you initiate treatment here. When you decide not to treat, or even in the setting of treatment, ongoing monitoring is incredibly important. With regular PFTs, often walking oximetry, CTs can be considered, and this is an important adjunct to monitoring patients, but we do know that many of these patients are younger, and so we want to balance the risk of radiation against the information that will be obtained. So PFTs really are the mainstay of monitoring in this situation. I want to bring your attention to recent guidelines that came out from the American College of Rheumatology regarding treatment of connective tissue disease ILD, which is now becoming known as SARD ILD, or treatment of systemic autoimmune rheumatic disease. One thing I'll mention is that the data behind these recommendations is not amazing in terms of quality, and so many are suggestions rather than true recommendations. One thing that was clear is that steroids may be used initially for many connective tissue diseases, but the strongest recommendation that actually came out of this group was against corticosteroids in systemic sclerosis because of the risk of renal crisis in this patient population. You'll notice in this top box, which is first-line therapies, that mycophenolate is mentioned as a top choice for many of the different diseases. In systemic sclerosis or scleroderma, nintedanib is also listed as a first-line agent, and I'll show you the data on that in just a minute. In the bottom part of the slide, for people who progress while on first-line therapy, what you can see is there's a number of different drugs depending on the specific diagnosis, but that nintedanib is available for all of the different diseases with progression. There are some data around pirfenidone in rheumatoid arthritis leading to a recommendation there, though it is actually not an approved medication for this indication in the United States. What we also know about treatment in this patient population is that it matters a lot, specific issues that the patient has in terms of comorbidities and their own personal concern and communication about goals of therapy. So specific comorbidities, including liver, GI, cardiac, thromboembolic, and renal insufficiency, all might affect what drugs you choose. But on a patient level, fertility concerns and concern around side effects is going to be quite important. I want to briefly show you the data where the antifibrotic therapy came from in these different patient populations. So in the scleroderma population, Census and Census On looked at the role of nintedanib versus placebo and showed that there was less decline in lung function in the nintedanib group than in the placebo group. Half of these patients were on mycophenolate already, and so it can be an add-on therapy or it can be used with the mycophenolate upfront. A lot of what we know about nintedanib in the general progressive fibrosis population comes from the INBUILD study, in which a group of patients who had progressive fibrosis in the last 24 months were enrolled, and there was a reduction in lung function decline in the nintedanib group. A lot of these patients did have rheumatoid arthritis, but it was really a mix of patients, but quite similar data to what we see in IPF. Similar to IPF, there's a lot of work being done in the progressive fibrosis field in terms of antifibrotic therapy. Clinical trials are incredibly important in this. Likely, the therapies will be focused more on the fibrosis, and people may be grouped together in this way. Inhaled pirfenidone and inhaled treprostinil are being studied, but importantly, nerandomilast, similar to IPF, was also shown to have a reduction in lung function decline in patients with progressive fibrosis. So similar to the IPF study, there were 2 different doses used. And similarly, the patients had less decline in the nerandomilast group. It didn't matter if they were on antifibrotic therapy or not, they did have effect of the drug. I do want to mention the non-pharmacologic treatment of fibrotic interstitial lung disease because this is incredibly important. Supportive care is something that really matters to patients and really can improve quality of life. So it's important to walk patients and uncover exertional hypoxemia and give them oxygen for exercise if that's something that they need. Often sending them to pulmonary rehab can uncover this exertional hypoxemia and can help teach them about how to use oxygen and also improve their exercise capacity through muscle building and through cardiac endurance. It's also quite important in evaluating for lung transplant because they need to be fit to be able to tolerate lung transplant. Lung transplant should be addressed in patients who are progressing significantly. I do want to mention something about reflux. In early guidelines of IPF, it was potentially recommended as a treatment for the lung disease, but that is no longer true in current guidelines, though it should not prevent you from treating reflux in a symptomatic patient. So let's go back to our case, the 78-year-old man who was recently diagnosed with IPF. So I think he's a good case study of what can happen with different medications. So ultimately, he had a discussion with his providers about the 2 antifibrotic medications available, the nintedanib and pirfenidone. And ultimately, he chose to take nintedanib because he was a snowbird, spent a lot of time in Florida, and elected to avoid the pirfenidone for the risk of photosensitivity concern. He began the nintedanib at 150 milligrams and initially was doing well, but then started to develop diarrhea about twice per day. He had recounseling about diet and protein intake with the drug, as well as with using antidiarrheals to try to avoid some of the side effects. And those did get better, but he then had LFT elevations. And ultimately, the drug was briefly held and was dose reduced, and he has been able to continue on. His disease did progress, which does not necessarily mean that the drug is not working, and he had then elected to enroll in a clinical trial. So to wrap up, I do want to remind you that antifibrotics are the standard of care treatment for IPF. There are emerging therapies for IPF that may become available. For progressive pulmonary fibrosis, you really want to think about the precise diagnosis to help you in treatment strategy. But antifibrotics are a significant option here and may ultimately become a standard of care for everything fibrotic. You do want to think about the side effect profile and trying to prevent side effects from the antifibrotics. You want to carefully counsel about diet and antidiarrheal use in nintedanib and about sun exposure in pirfenidone. And ultimately, you do want to temper expectations. Patients who expect an improvement from antifibrotic therapy are less likely to stick with the drug. But what really is going to happen is that their lung function decline may be slowed, and that may be difficult for them to sense as their symptoms will not improve.